Hi guys, we're going to talk about chapter 42. When we think about bowel elimination, we're referring to the secretion and excretion of body waste from our body. Nurses, however, will encounter children with various GI disorders and will need to understand if these disorders are acute, or are they chronic, or are they life-threatening. So let's just get started here. So anatomy and physiology, this should be real review for you, right? It starts at the mouth, highly vascular, portal of entry for infection. We've discussed that infants and young children bring objects to their mouths. They explore the world in this fashion. This just increases the risk for infectious agents getting into their system. Then we hit the esophagus. The lower esophagus sphincter is not fully developed until about 1 month of age, which causes some regurgitation or backflow. This gets better as the child ages, but may still be apparent until the age of 1. Then we hit the stomach. Newborn capacity is only about 10 to 20 mLs, and it increases to about 200 mLs by 2 months of age. The intestines, the small intestines are not mature at birth, and a full-term infant has approximately 250 cc's of small intestine compared to that adult of 600 cc's. The liver is relatively large at birth. Pancreatic enzymes develop postnatally until about 2 years of age. And then fluid balance and losses we always have to be mindful of. Children lose fluid easier and faster. It takes a lot more fluid per their body weight to keep them hydrated. And nurses should be keeping this in mind because this puts them at high risk for fluid balance issues. So there are many different medical treatments for our GI disorders. Hydration, these are fluids that can contain certain amounts of electrolytes and glucose to help prevent dehydration and promote rehydration. Excuse me, guys. Fluid administration should begin prior to the onset of dehydration. So when we think about oral rehydration therapy, this should contain sodium chloride, glucose. Our standard solutions are usually our Pedialytes, Infulites, and Ricelites. It's really not appropriate for oral rehydration. Our tap waters, milk, undiluted fruit juice, soups, broths, those aren't going to help oral rehydrate. Those are just going to give hydration. Mild to moderate dehydration requires 50 to 100 mL per kilo of that oral rehydration solution over about 4 hours. Children that have diarrhea, right, that puts them at risk. If they are becoming dehydrated, we're going to treat them with this oral rehydration therapy. That's just a perfect example for you. Once they've rehydrated, then how's that health provider going to know if they're better? Then we can check that urine specific gravity, right? It should be more normalized than like a 1.015 versus a more concentrated because they're dehydrated. So if we're applying that sodium chloride, the glucose, right, it's going to make our urine balance, which is going to cause better hydration status. Another medical treatment we can think about is providing adequate nutrition, and this can be done orally, enterally, or IV. Feeding tubes can be placed for those with feeding difficulties, failure to thrive, reflux, or even chronic illnesses. IV therapy can be done for our dehydration, bowel rest, or even NPO status. Enemas and bowel preparations might include, we can perform those with fecal impaction or severe constipations. Right, if you haven't done an enema or a bowel prep, welcome to nursing. You're probably going to get to do that if they've got a fecal impaction or severe constipation. Ostomies is another medical treatment that we've talked about previously. Again, this is a surgical opening into that digestive organ. Portions of the intestine need to be brought up to the level of the skin, and this is usually indicated for imperforated anus, gastroschisis, Hirschsprung's disease, necrotizing enterocolitis, maybe Crohn's disease, or even ulcerative colitis. And so again, this is just a picture of those stool diversions. And we hit this quite a bit back in your concepts or fundamentals class. So again, just bringing that intestine up to the surface for those stool diversions. We do need to make sure we educate our family on ostomy care, so that we're preventing further complications. As far as ostomy care, if you want to remember stoma, we're going to set up the equipment, take off the pouch, observe the stoma, measure the stoma, and then apply the new pouch. And we'll have to educate our families really well before they go home with their kiddos that have these. Probiotics are helpful when we have diarrhea. It helps with the treatment and the prevention of. It just helps support and replace the intestinal microbial flora. And then let's talk about solutions here. So as far as histamine 2 blockers, these decrease our histamine production. Prokinetics stimulate the GI motility to help empty the stomach. Antibacterial or antibiotics, right? They help treat bacterial infections. Corticosteroids reduce inflammation. These are usually seen, we use these a lot with our inflammatory bowel or autoimmune diseases. Stimulants or laxatives help stimulate the peristalsis and help soften the stools. Antidiarrheals or antiemetics decrease peristalsis. Anticholinergics help control abdominal spasms, cramping with irritable bowel disorders. And then our anti-inflammatories reduce inflammation with those maybe with ulcerative colitis. Common labs and diagnostics. Abdominal ultrasonography visualizes abdominal organs. This is usually indicated if they've got abdominal pain, vomiting, pregnancy, enlarged organs. On palpation, we'll do an ultrasound. Barium swallow visualizes the peristalsis activity and motility of the esophagus, stomach, and upper GI tract. Blood work, amylase for acute pancreatitis, cholecystitis or trauma, electrolytes to help determine the extension of dehydration, lipase, again for pancreatitis, cholecystitis, or peritonitis, and LFTs to help evaluate if there's a disease process going on in the liver. Esophageal pH probe tests the esophagus for normal contractility and effectiveness of swallowing. Endoscopy can visualize the hepatobiliary system by using some type of contrast. Hemocult, stool sample, culture, stool O&P. We need to know how to collect stool as pediatric nurses. So we can do this in many different ways, right? If we have a diapered patient, we may need to use a tongue blade to scrape a specimen into a collection container. If our patient has runny stools, we may need to place a piece of plastic wrap in the diaper that can catch that specimen. A very liquidy stool may require application of a urine bag just to that anal area. If we have an older ambulatory child, we can have them urinate in the toilet and then poop in the hat, and then we can catch that specimen from a clean collection. If they are bedridden, we can again collect that specimen from a clean bedpan without having the specimen be contaminated again with urine in the bedpan, because that would just alter our results. Hepatobiliary scan visualizes the gallbladder, determines patency. Liver biopsies help hepatic structure, and then lactose tolerance tests, urea breath tests is usually done after kiddos have ingested lactose to test those levels of hydrogen. So all those common labs and diagnostics you'll see with our GI. Okay, so let's talk about a GI assessment that needs to be performed, again, from least invasive to most invasive. We're obtaining the subjective data in the least invasive means to get lots of answers regarding our GI concerns. We can talk about lifestyle. This includes family history. We can talk about diet. We can also talk, are they gaining weight? Do they have problems with feeding patterns? any allergies, lactose intolerance, celiac disease. And then we also want to talk about elimination patterns. What's their intake versus their output? Do they have encoparesis or constipation? And that's just going to get you really started with that. And then we're going to collect the objective data. That's the next step, being mindful of least invasive to most invasive. Again, that is really important with our abdominal assessment. We want to make sure we look, listen, feel, look being least invasive of the three. So we're going to observe and inspect. We're going to look at color. Is their skin pale? Do they have pale lips? That can happen with some of our GI disorders and could indicate anemia or dehydration. Maybe they have yellowing or jaundice that might be noted. Looking at the sclera, because that could even be yellowed. As far as hydration, mouth should be moist and pink. Skin turgor, we can check it on the chest. If it's decreased, that would indicate dehydration. Infant and young children crying should have tears. As far as abdominal size, the abdomen should be flat when supine. Any bulging of the abdomen would suggest the presence of ascites, fluid retention, gas distension, or even a tumor. So now that we've looked, now we can listen. Next, least invasive assessment measure, we're going to auscultate. Hyperactive and hypoactive bowel sounds. If they're hyperactive, we may see that with diarrhea, gastroenteritis. If they're hypoactive, we may see that with some type of an obstructive process. Absence bowel sounds, we have to listen for a solid 5 minutes. So 1 minute in each quadrant with an additional minute until we can call it absent bowel sounds. Feel is the last of the objective data collection and the most invasive component of this assessment. Percussion is not typically done with kiddos. We're going to palpate light to deep. Tenderness is not normal. So we need to know if there is tenderness, we need to know where it's located. If it's in that right upper, that could indicate liver. Right lower with a rebound could indicate an appendicitis. Remembering that tenderness is not normal. Document those findings and then make sure your provider is notified. All right, so some of the structural anomalies of the GI tract that we're going to just take a quick peek at are cleft lip and palate, hernias, inguinal and umbilical, and then that mechal diverticulum. So cleft lip and palate is the most common congenital craniofacial anomaly. The most common anomalies associated with this may include heart defects, ear malformations, skeletal deformities, genitourinary abnormalities. Complications of cleft lip and palate include feeding difficulties. Infants born with cleft lip may have difficulty forming adequate seal around a nipple in order to create that necessary suction for feeding, and they may also experience excessive air intake. Other complications include altered dentition, delayed or altered speech development. Speech development should be clear around age 4, or additional surgeries may need to be performed, and otitis media. The opening in that palate contributes to buildup or fluid in that middle ear. So what can we do for these parents and these kiddos? Nursing management is going to include, 1, preventing injury to that suture line. So we want to make sure we position well. This is going to help prevent injury to that suture line. The infant should be placed in a supine or sideline position. Arm restraints may be necessary to keep their hands from touching their face or entering their mouth. We want to promote adequate nutrition as best we can. We want to encourage infant-parent bonding. The appearance of their baby may be appalling to the parent. Make sure we're encouraging our parent to hold and to rock that baby to help soothe them. And then we want to promote emotional support. Remembering our healthy infants can create some anxiety for our families, and now they have delivered a baby with a medical condition. All right, so hernias, the focus is on inguinal because that tends to cause more issues than umbilical. These defects that occur during fetal development, part of the lining in the abdomen that is failing to close, allows the abdominal or pelvic viscera to travel through the internal inguinal ring and into the inguinal canal. Hernia sacs then develop. Boys are more likely than girls to develop these. Sacs are filled with bowel in boys and fallopian or ovaries in girls. Surgical intervention to correct these. Typically make sure the patient's thriving before we perform the surgical procedure. So they will probably be several weeks old unless bigger problems are occurring. Most parents are going to see the hernia when their baby is crying or straining. It may not be seen during a clinic visit unless the provider can make the patient cry or strain, and then they will see it. The biggest concern with hernias are strangulation, incarceration, and reducibility. So you can think about the mnemonic SIR hernia to help remember these complications. So strangulation of the hernia, this is when it's trapped outside the peritoneum cavity. This is an emergency situation because the blood supply is being cut off. They would need to go to surgery to correct this immediately. Incarceration is when it's trapped outside the peritoneal cavity. They may need to reduce it or surgically fix it. And then reducible, this is when it moves back into the peritoneal cavity. We can actually teach our parents to push the hernia back up into the abdominal area so that the bowel does not become strangulated. This is just a temporary fix, and eventually they will need surgery for this. So Meckel diverticulum, this is one that you may not have ever heard of. It is the most common congenital anomaly in children of the GI tract. Many have this and don't know they have it until it becomes an issue. So there's a bulge from the intestine that used to connect to the umbilical cord. When the supply from the bloodstream is cut off at birth, that leftover umbilical cord may be left over in the abdomen. This causes a fibrous band to connect to the small intestine to the umbilicus. Bleeding can be a concern, which can cause anemia, and obstruction can be a concern, which could cause volvulus or intussusception. Because it had a high supply of blood, that bleeding again can cause anemia. If complications occur, this is usually going to happen before the age of 2, and surgery will be required to remove that diverticulum. So when our patient comes in, we're assessing for a bowel disorder, we're going to look at those signs and symptoms. So bleeding, anemia, severe colicky, abdominal pain, abdominal distension, hypoactive bowel sounds, guarding, abdominal mass rebound, tenderness. Conclusive diagnostic test is going to be a Meckel scan. As far as management, we're going to make sure that we are administering any blood products or IV fluids. If they have really severe anemia, maybe some packed RBCs, we're going to maintain an NPO status prior to surgery. We can perform pre and post-op care and teachings for our family. Any acute abdominal pain before or after surgery needs to be reported. Something more significant could potentially be going on. All right, so let's look at some of our acute GI disorders. We are not going to go over all of these. The ones that we're really going to focus in on are dehydration, pyloric stenosis, and intussusception and appendicitis. So let's look at dehydration here. This occurs more frequently in infants and young children. We know the risk is higher because they have increased extracellular fluid percentage and body water compared to our adult population. So we're going to look at an assessment. We're going to focus on that heart rate, respiratory rate, skin turgor, fontanelles for our infants. We're going to look at oral mucosa, knowing it's typically pink and moist, but with our dehydration, it could be dry, cracked, or even tacky when we feel in their mouth. We're going to look at temperature, mental status, and urine output. There is a really great chart in your book that compares mild, moderate, and severe dehydration, and we're going to look at that in just a second. As nurses, we need to decide how this dehydration should be managed, depending on if it's mild, if it's moderate, or if it's severe. Mild dehydration, we can usually take care of that with oral rehydration therapy. That's our Pedialytes, our Insulites that we talked about earlier in this chapter. If we're talking about moderate to severe, then we're looking at IV fluid replacement. Risk factors with our dehydration kids, you can see listed here: diarrhea, vomiting, decreased oral intake, high fevers, DKA, or extensive burns are definitely risk factors that our patients are going to get dehydrated. Then we have to determine, is it mild, moderate, or severe? So here's this chart that is in your book, and it really just compares mild, moderate, and severe dehydration. For mild dehydration, sometimes this can be really hard to detect because the child may be alert and may be acting very normal with normal vital signs. Some of the signs that we might see are, we'll still see moist mucous membranes. We may still see a normal cap refill of less than 2. A lot of times their weight loss may be up to 5% of their body weight, depending on when this started. Urine output may be normal or slightly less. So you can see that chart there, lots of normals within our mild dehydration. So this is when we can do some oral rehydration for them. When we look at moderate dehydration, now we have more dry mucous membranes. Maybe our cap refill's more delayed. Now our weight loss, body weight loss is 6 to 9%. This is when they become more irritable. They become more lethargic. They're unable to play. Their fontanelles may be more sunken in. Heart rate is going up, so they're tachycardic. Their blood pressure is decreasing. So you can see the difference in just mild to moderate, how declined they can get. Now let's compare that to severe and how much worse off they can get really fast. Weight loss is greater than 10%. They're lethargic. They may even be comatose at this point. So we've gone from normal acting to irritable to now comatose. Pulses are weak and rapid. Blood pressure continues to decrease or may be undetectable. Respiratory rate will be varied and will be very labored. Mucous membranes are now dry and tacky. Fontanelles are sunken in, and there's little to no urine output with these patients. We have to act really, really quickly if they get to this severe point. All right, so let's talk a little bit about pyloric stenosis. The circular muscle of the pylorus becomes hypertrophied, causing thickness in the luminal side of the pyloric canal. You can see that on the picture there. This thickness creates a gastric outlet obstruction, causing non-bilious vomiting, usually between 3 to 6 weeks of life. I've seen information that it can go up to 8 weeks of life. So anywhere between 3 to 8 weeks of life is when you're going to see pyloric stenosis. If the child is greater than 8 weeks of life, this is not pyloric stenosis. The cause is unknown. It usually affects males 2 to 5 times more than females. It's usually present at birth, but we don't see it until at least 3 weeks of age. And it's usually diagnosed by an ultrasound. So what a nursing assessment is going to include eliciting information of the present illness and chief complaint. Some common symptoms include initially they're going to have that regurgitation after meals. So the parent may say, oh, they have just this little bit of spitting up every time they feed. Then within a week, it's going to be projectile vomiting, right? Because that muscle has thickened and that opening is getting smaller and smaller. So within 1 week, projectile vomiting. It's forceful. It may spew 2 to 4 feet. Vision that, right? This is not just vomiting like you and I vomit, right? This is like spewing out of their mouth type of vomiting, hitting the wall on the other side of the room. The infant is constantly hungry. They usually do have some weight loss because of all of the vomiting. And you will feel a palpable olive-shaped mass in that right lower quadrant. It can be hard to feel, but if you can't feel that and you have all of these symptoms, then they're definitely going to do other testing before they go into surgery just to solidify this. Most of the time it's an ultrasound. If surgery is warranted, the pylorus will be stretched out or cut open. That's called a pyloromyotomy. Remember that this is a healthy infant, right? They were born with it, but we didn't show signs or symptoms until 3 to 8 weeks of life. So this is a healthy infant, which is just going to increase anxiety for our family, right? We're going to need to provide some emotional support for them because our healthy infant who's got some vomiting is now going to surgery. All right, intussusception is the next one, and this is a process that occurs when the proximal segment of a bowel telescopes into the distal portion of the intestine. So those of you that maybe fold your socks within each other, think about that. The walls of the segments of the intestine press against each other, causing inflammation, edema, and decreased blood flow. An incarceration occurs, necrosis results with hemorrhage, perforation, and peritonitis. Most of the cases of intussusception occur in our toddlers. There's a classic triad that happens, and the three main symptoms that you're going to see are severe episodic pain. It's going to be sudden onset. They're going to drop the knees. They're going to guard. They're going to protect that belly. They can have some vomiting that could occur over time. Current jelly stools is the second symptom in our triad. The stools change from brown to blood tinged and mucousy, referred to as current jelly stools. Most patients will test positive for blood in the stool, and they will also have this sausage-shaped mass, which is the hallmark sign in that right lower quadrant, which is our third symptom of the triad, is that transverse sausage-shaped mass. And that again is our hallmark sign for intussusception. So as far as treatment, the child that is asymptomatic and may appear well may be a sign that the bowel has reduced spontaneously. This does occur in about 10% of our cases. If it doesn't reduce spontaneously, we're going to need to do a barium enema. Sometimes those barium enemas successfully reduce a large percentage of intussusception cases. We're going to do that barium enema with the presence of a surgeon. So that surgeon's going to be on hand when we're doing that enema. If the enema doesn't work and doesn't correct the intussusception, then they're going to have to go to surgery. Surgical intervention is the last resort, but it has to be done if there are signs of perforation or peritonitis. After surgery, the patient will be placed on clear liquids such as oral rehydration therapy to make sure they can tolerate those liquids. Then they will advance to formula breast milk once they can demonstrate that they can tolerate that oral rehydration therapy. So what are some risk factors for intussusception? A lot of these are really due to inflammatory conditions of the bowel. Male, that's not inflammatory, but being male, you have a higher incidence. Meckel diverticulum, again, that's an inflammatory process. Duplication cysts, polyps, appendix, cystic fibrosis, celiac disease, Crohn's disease, right? A lot of those are inflammatory conditions that can just put you at risk for intussusception. All right, let's move into appendicitis. Appendicitis is an acute inflammation of the appendix. Fecal matter gets into the appendix, causing inflammation, which possibly leads to rupture, making this an emergent abdominal surgery. Early diagnosis and intervention are key to assessment to avoid perforation. We're going to assess, as far as nursing assessment, common signs and symptoms include vague abdominal pain, initially localized to the upper right quadrant, small volume, frequent stools, fever. If the patient's pain subsides, we have a problem that we would be concerned that it perforated and we need to notify that physician immediately. Often they are unable to walk or climb on examination table. A lot of times we'll have them try to do a jumping jack. If they are unable to do that, could be a very clear-cut sign. Upon palpation, maximal tenderness occurs over the McBurden point. As far as nursing management, we're going to do pre and post-op care, and they will usually get 72 hours of antibiotics to prevent any post-op infections. So common labs and diagnostics for appendicitis specifically, abdominal CT scan, that's going to help visualize the appendix for further evaluation. Lab testing may reveal an elevated white blood cell count, which would indicate infection, and C-reactive protein may also be elevated, which would also just indicate inflammation. All right, that's all of our acute ones. Now, our chronic GI disorders. We can talk about reflux or peptic ulcer is chronic. We can talk about constipation or encoparesis. So constipation is a very common problem among children and can be defined as failure to achieve complete evacuation of the lower colon. Bowel habits of both infants and children will vary widely, so we need to assess and treat each child as an individual. Some of the causes of constipation are broken down, and you can see them on this table here. Hirschsprung's disease is a disorder of motility that results in obstruction. Short bowel syndrome is clinical syndrome of nutrient malabsorption and excessive intestinal fluid and electrolyte losses. Inflammatory bowel disease may include Crohn's disease or ulcerative colitis, and we're going to talk about that one. So Crohn's disease and ulcerative colitis are unknown. We don't know the causes of these disorders. We do know that they are inflammatory processes of the GI tract. Some of the signs and symptoms may include abdominal cramping, nighttime symptoms, including waking during abdominal pain or urge to defecate, fever, weight loss, poor growth, delayed sexual development are all signs and symptoms. So how do we manage? We're going to focus on teaching about the disease management, nutritional management, medication therapy, and then promoting family and child coping. Celiac disease is another one on here. So celiac disease is a chronic malabsorption syndrome, immunologic disorder in which the gluten causes damage to the small intestine. So gluten is a product commonly found in grains. The villi function is to absorb nutrients into the bloodstream. When the villi are damaged, malnutrition occurs. So you can see there on the picture, we have normal villi that are nice and tall and fluffy. The damaged villi are flat, which has a lot less surface area to absorb those nutrients and the food. Only current treatment right now is a strict gluten-free diet. We have to educate to adhere to that diet so that those villi can heal and function more normally. This is a lifelong dietary restriction because even the smallest amount of gluten introduced back could cause damage again to those villi. Lots and lots of symptoms here on the picture. The most common ones are in red. I will let you read over each of those. Often these symptoms are present around the age of 2. Signs and symptoms are diarrhea or steatorrhea, which are fatty stools that are greasy, foul-smelling, frothy. That is really the most common sign or symptom that you're going to see. It can also cause constipation, but most of the time you're going to see that steatorrhea. Failure to thrive, weight loss, just because they're unable to absorb nutrients and foods. You'll see some abdominal distension and bloating. So you can see that picture in the right, that big belly with those tiny little legs and booty, right? That's very common. They have poor muscle tone because they just don't have the ability to build muscle because they're not absorbing the nutrients appropriately. Labs and diagnostics, transglutamase IgA is the most sensitive lab. If it's negative, but you really feel convinced that this is a celiac kiddo, then we can do other testing such as an anti-endomycin. Let's see. The challenge for this disease process is adherence to the strict gluten-free diet. We may need to encourage the entire family to follow the diet so that one, we're not leaving that kiddo out, and two, the parents aren't having to cook 2 different meals every time they want to eat. Other chronic GI disorders are recurrent abdominal pain, failure to thrive, and chronic feeding problems. So as far as psychosocial concerns, we just need to be mindful, right? We may be considered medically fragile for a lengthy period of time, these kiddos. Lots of anxiety, especially related to any bowel resections that could happen. Parents are going to miss work and time with other kiddos if they have one child in the hospital for a really long time. Encourage the families to become more experts in their child's needs. They're going to be the ones that spend all the time with them. Provide teaching so that the parents feel empowered, so that when they do go home, they feel capable of taking care of this child. And that concludes chapter 42. If you have any questions, you can shoot me an email or we'll chat about it in class. Thanks, guys.